Hello, and welcome to the Dance Physio Podcast, a podcast designed to explore ideas and foster discussion around dancer health and wellness. We're here to challenge the status quo, bridge the gap between dance science and the studio, and help change the landscape of the dance industry for the better. I'm your host, Erika Mayall, a dancer turned physiotherapist who is deeply passionate about leaving the dance world better than I found it. I'm so glad you're here. Let's get started.
Hello, everyone, and welcome back to another episode of the Dance Physio Podcast. I am your host, Erika Mayall. Today, we are going to be talking all about dancer's fracture, or what more specifically is a fracture of the fifth metatarsal. And sometimes injuries seem to come in clusters a little bit, and any probably medical professional, and specifically like physios and chiros and stuff, will probably tell you that you often see like injuries happen in sort of waves or in groups. And so you'll see like something not for a really long time and then see a bunch of them all at the same time. And earlier this year, kind of in the spring I would say spring, I was seeing all sorts of patellar dislocations. That was kind of like the injury where I hadn't seen one in ages and then had like a bunch all at the same time. And currently, the injury that keeps kind of popping up is this dancer's fracture. And that's not to say I'm seeing like dozens of them or anything, but it's just interesting because haven't seen one in ages, and then there's been a couple recently. So I figured I would do a podcast episode about it, just because it is common in dancers, hence the name dancer's fracture. So that's kind of something that this gets called often. But like I said, this is a fracture of the fifth metatarsal. And specifically, this is usually a spiral or an oblique fracture of the shaft of the fifth metatarsal bone. And so the fracture, if you see it on x-ray, it will look like it's kind of on a diagonal through the bone. And so there are other types of fractures that we see in the fifth metatarsal as well. And sometimes these all get lumped into being called a dancer's fracture. But in reality, if we're going to be really picky about our words, which I often am, a dancer's fracture is that shaft of the fifth metatarsal. And like I said, it's almost always like that spiral or oblique kind of fracture. And I'll explain why in a minute. But the other types of fractures that we might see that are really common, again, in dancers, but these technically aren't classified as a dancer's fracture, but an avulsion fracture of the fifth metatarsal is usually, it is at the base. So this is the part of the metatarsal. So the metatarsal is the long bone in your forefoot just before where your toes are. And the fifth one is the one closest to your baby toe. So the outer part of your foot. So it's like that outer edge of your foot there. And the base of the fifth metatarsal is the part of that bone that is closest to your ankle. So not towards the baby toe, but towards the ankle. And an avulsion fracture means that a part of that bone has sort of been pulled away because there's a tendon that attaches into that bone that comes around from the outside of the ankle. And oftentimes in sort of ankle sprain type movements or mechanisms, that tendon or the muscle will contract really suddenly, and the tendon pulls hard enough on that bony attachment that it can pull a little piece of that bone away. And so we call that an avulsion fracture. And that, like I said, is different than a dancer's fracture. And we do see those commonly in dancers and in other people as well, but that's not exactly what I'm going to be talking about today. And the other type of fracture in the fifth metatarsal that, again, we see commonly but isn't technically a dancer's fracture is what is called a Jones fracture. And so these fractures occur in the what we call more distal end of the fifth metatarsal. So this is closer to the baby toe, so closer to like the kind of the front of your foot. And these fractures, again, can be quite common. They can be a little bit more problematic because that part of the fifth metatarsal does not have as good blood supply as some other parts of the bone do. So sometimes we see sort of more cases of delayed healing or non-union or other complications of that fracture. So Jones fractures, again, they are technically a different injury, and sometimes they get treated or managed differently. So for today's episode, for these purposes, I am going to talk specifically about this shaft of the fifth metatarsal. So a true what we would call dancer's fracture. So how do these fractures occur? Why are they so common in dancers? Well, they generally occur with some sort of a twisting motion that happens sort of through the ankle or the foot area. And the most common way that happens is somebody rolling over on their ankle. So the same mechanism that we would see a lateral ankle sprain, or we call it an inversion ankle injury, so your foot kind of turns inwards, that same twisting movement can cause this type of rotational stress that causes this spiral fracture in the fifth metatarsal. And it most commonly occurs when we have this twisting motion that also happens when the foot is in what's called a plantar flex position, but is essentially your foot in like a bit of a pointed position. So if our foot was flexed up and then we inverted, we might be more likely to damage some other sort of structures in the foot. But if our foot is pointed and then we roll over on that ankle or have that twisting motion, that is when we commonly see the shaft of the fifth metatarsal fractures. And that is one of the reasons that they are so common in dancers, is because we spend a lot of time with our ankle in plantar flexion or with our feet or ankles pointed. And we also, if you're dancing like on point, then you're in that plantar flex, like true end range plantar flexion. And then if you roll your ankle from that position, you're likely to get those kind of rotational or twisting forces going through that base of the fifth metatarsal. So that is the most common way that we see these injuries happen. And like I said, this is also kind of the mechanism that we see a lot of ankle sprains happening. So a lot of times people will have that mechanism of injury and assume that they've sprained their ankle. But when we actually kind of examine them, or when we're sort of assessing, we're like, ooh, actually, I think we need to go get this like assessed to see if there is a fracture there, either in addition to ligament damage, if it was an ankle sprain, or sometimes it's actually just a fracture and the ligaments themselves are kind of fine in through there. If you want to know more information about ankle sprains, there is a podcast episode about that. I will link it in the show notes. I don't off the top of my head know what episode number it is, but if you're interested in the mechanism or like what we're seeing in a typical ankle sprain when the ligaments are involved, you can go have a listen to that episode. But in this case, we're just going to talk about what happens when the actual bone is injured in through there. So we have that kind of twisting motion as being the most common way that these dancer fractures occur. The other thing that we sometimes see is these fractures being related to stress fractures. And so that fifth metatarsal, so again, the outer side of the foot, it is a common bone that we see stress fractures occurring in. I will say, though, that if we're going to be really picky about how we're actually talking about this fracture and the language we're using, it is more common to see a Jones fracture or a fracture happening in the more distal end of the fifth metatarsal being from a stress reaction or a stress fracture injury, as opposed to this kind of mid-shaft and, again, usually oblique or spiral fracture happening. So these pure dancer's fractures are maybe slightly less common as a stress fracture than, say, a Jones fracture, but that's not to say they can't happen. So fifth metatarsal is a common area for stress reactions and stress fractures in dancers, and it could be along that shaft of the fifth metatarsal. And what probably happens sometimes is there's probably some amount of a stress reaction or a stress fracture that has happened, and then maybe somebody rolls over on their ankle and it's just enough because the bone's already weakened in through there that's enough to cause the actual fracture to happen. So sometimes the actual mechanism of like how the injury happens seems relatively minor, and that could be if there was already some bone stress happening, underneath. But for the most part, these are acute, more traumatic injuries where somebody rolls their ankle, there's that sort of rotary or twisting movement, and we see that oblique or spiral fracture happen through the fifth metatarsal. So how are these diagnosed? Well, like I said, we want somebody to go get x-rays. So a lot of the times people right away, they can't weight bear, it's super tender. Like right after the injury, people will realize something's wrong and go and sort of have x-rays or done or go get assessed. But sometimes people are able to weight bear with these injuries. And like I said, they'll assume it's an ankle sprain and come into the clinic for assessment. And with some of our assessment tests that we do, it becomes apparent that we're like, ooh, I actually think this might be an issue with the fifth metatarsal. So we may recommend people go and get x-rays. And on those x-rays, they're looking for, like I said, that oblique or kind of diagonal line of a fracture through that fifth metatarsal. The x-rays may show that the fracture is what it is. Let me start that again. The x-rays will show whether the fracture is displaced or whether it's stable. And so all that means is if a fracture is stable, it means the bone's still lined up really well and it just has that fracture line going through it. And a displaced fracture often means that the bones are no longer in sort of like proper alignment. And so if it is a displaced fracture, they will look at reducing that. So they're going to do something to line those bones up. Sometimes they can do that just like manually externally, and sometimes they actually need to go in and surgically stabilize that depending on how displaced it is or if there's like fragments of a bone or things like that. But most of the time, these fractures can be treated what we call conservatively, so not requiring surgery, like they can be treated sort of without surgery, and generally do quite well with with conservative treatment, with non-operative treatment. So the vast majority of these cases do not necessarily require surgery, but we still want to know whether it is displaced or undisplaced because that will determine kind of the level of protection that we might be looking at with conservative treatment. So when we are looking at treatment with these injuries, there is going to be some amount of immobilization and generally protected weight bearing or even non-weight bearing for a period of time. So if you have a fracture that is not displaced, so it's quite a stable fracture, sometimes they will not necessarily cast or boot these fractures. They may just recommend a rigid shoe. So they have these little, I don't even know what they're called. Like a thing that goes on your shoe basically to stop the sole from bending. So it basically makes your shoe like really rigid. So sometimes they'll do something like that. Most often though, they are going to recommend a walking boot because it's the easiest way of immobilizing these. Generally, they don't use casts for these types of injuries unless, like I said, they've had to surgically stabilize it or there's been, quite a traumatic break where there's, like I said, maybe a lot of fragments or something, in which case they might be more aggressive about that. But the vast majority of cases and all the ones I've ever treated, they usually use a walking boot to immobilize people. And generally, again, if the fracture is fairly stable and not displaced, you are allowed to weight bear with that boot on fairly early on. And it usually has to do with how much pain you're having. So they'll kind of say weight bearing as tolerated is usually like the language they'll use around that. Sometimes it's recommended to be non-weight bearing for the first few weeks, sometimes up to like 3 weeks, depending again on what the fracture looks like on x-ray. And so when you have that assessed, the doctors will give you more information about that. But in some cases, people may be able to weight bear with that boot on, so it's immobilized, but weight bear right away. So again, we're protecting it, we're immobilizing it, and then your weight bearing status may be modified or it could be just within tolerance. Generally, immobilization or wearing a boot is going to be for about 6 weeks' time. Again, it's going to depend on how well things are healing. They'll usually re-x-ray around 6 weeks and try and decide like how well the bone is healing. And if it's showing good amounts of bony healing, then usually people will, be told that they can take the boot off. They don't need to immobilize it anymore. And then they can start gradually increasing the amount of activity that they're doing, the amount of weight bearing they're doing, and gradually building up kind of strength and mobility and all of those sorts of things. During that first 6 weeks of generally like immobilization and sort of modified weight bearing, this is a really, really good time for dancers to work on other areas of conditioning. So just because you can't be doing lots of stuff with that foot in particular does not mean that there are not other things that dancers can be working on. And so we often will have people for the first few weeks maybe have just like a bit of a complete rest, complete break because we want to focus on healing. We want to make sure that pain is under control, swelling and inflammation are under control, all of those types of things. But pretty quickly within the first few weeks, we want dancers to get back to doing some amount of kind of conditioning and working on strength and stability and muscle balance and all of those sorts of things in other areas of their body. And so it is a really good time to start to work with a physiotherapist or physical therapist or whoever your rehab person is. I think a lot of people wait to start that process until they've been given the clearance by the doctor to that there is healing that's occurring in the fracture, but you can actually start so much sooner than that because, like I said, there's so many other areas of the body that you can start to work on even while you're not doing stuff specifically for that fracture if that foot is still immobilized. So usually we recommend starting rehab within the first couple of weeks, like sort of around the 3-week mark or something in there, so that by the time 6 weeks rolls around, or give or take maybe 8 weeks, but often around 6 weeks, if healing is occurring and you've been given permission to, take the boot off and to start to walk normally and all of those sorts of things, that you aren't starting the kind of rehab and conditioning process at that point. It's just a matter of continuing things on because you've already started it kind of weeks before that. So that's generally the recommendation, is we start things around then. And then around the 6-week mark or somewhere in that neighborhood is when we can start to really specifically focus on mobility and strength of the injured side. And so that often starts with looking at things like retraining walking, like gait patterns and weight bearing through the foot, making sure that people haven't altered their movement patterns. Then we're looking at range of motion of the ankle, range of motion of, the midfoot, the forefoot, and then working strength in all of those areas as well. So really specifically working on rehab of the foot starting at that point or whenever you've been given clearance by the doctor that there is sufficient bony healing happening to do that. And from that point on, then it's like that gradual progression back to returning to dance specific type things. And so that timeline can vary a little bit depending on the complexity of the fracture. So really straightforward fractures that are not displaced and that heal really well, people are often back dancing, sort of returning back to dance just a couple weeks after that sort of 6-week mark of when they've been given permission to not have the boot on anymore. We'll have dancers back doing, sometimes it's modified stuff still. There might be certain things they're not doing, but within kind of that 8-week timeline, some dancers are returning back. Other dancers, if it is a more complicated fracture, that return back to the studio can take longer than that. So we might be looking at more like 10, 12 weeks before they're starting to reintegrate into dance classes. And again, that might be with modifications. The thing that takes the longest with these types of injuries is returning to point work. So if you are a ballet dancer, oftentimes dancers are back doing other styles of dance or even doing ballet but not on point, and point can take the longest. And it is not uncommon for progressing back to point work to take 12 weeks or sometimes even 16 weeks to get people back being able to do point work. And again, that would be like a fairly straightforward fracture because it just requires so much strength to be able to be back in a weight-bearing position on point because there's so much force that's going through that fifth metatarsal shaft when you're in that position. And so that is definitely the thing that takes dancers the longest to get back to, is doing point work. But again, there can be huge variability within when dancers are able to do that. There was one study, and this was actually quite an old study, I can't remember exactly when it's from, but from the 90s, I think, that looked at professional ballet dancers who had all had these dancers' fractures. And I think they had, I want to say 30-something people in the study, maybe 35 people in the study, and the average time for them to get back to performing on stage, so these would be ballet dancers who are having to dance on point, like professional ballet dancers, was 19 weeks. But they also had some outliers who took a lot longer. So they had, I think the longest was up to it was 48 or 52 weeks or something, because there were some people that had some complications. So there were people who were back to performing within even 6 weeks. So there was huge variability within that study, but on average in that particular study, to have professional ballet dancers back dancing on stage in pointe shoes was 19 weeks. But like I said, a lot of people, it's going to be a bit sooner than that, but it's definitely going to be the last thing. So most dancers can get back to some amount of dance participation, and it might be still slightly modified between that 8 and 12 week mark. And then pointe work might take a little bit longer past that 12 week mark. And again, it will vary a lot depending on the severity of the fracture initially. So a non-displaced, really stable fracture might be a lot more straightforward than that versus somebody who's had a more complex displaced fracture, and certainly somebody who's had a surgical stabilization. That healing timeline is going to be a little bit longer. So that is some information for you about dancers' fractures. If you're interested in learning more stuff about some of the other types of fractures, especially the Jones fracture, because like I said, it is slightly different, let me know. I'm happy to do a podcast episode about that as well. The information is not massively different, but like I said, Jones fractures can be a little bit more complicated just because of the blood supply in the area. So they are treated a little bit more conservatively than this typical kind of dancer's fracture. So if you're interested, send me a message. They're not as common in dancers, so I may or may not do a podcast episode about it. But I hope you found that helpful, and I hope that I don't see any more dancers' fractures in the next little while, because I feel like I've seen my share for this year, certainly, and maybe for the next couple of years. So if you have any questions, reach out. I'm happy to answer them. And once again, thank you so much for listening. I really appreciate your time, and I hope you have a great rest of your day.